Okay, so now we're going to be talking about cellulitis, and this is also going to serve as kind of a lead-in to the next section, which is sepsis, because sepsis also has to deal with infection. So to start with, I included a picture of the cross section of the skin, just to kind of refamiliarize you all with the anatomy of the skin. When we talk about cellulitis, we're talking about an infection that is of the dermis and the subcutaneous layers of the skin. So not so much the epidermis, although you'll obviously see it on the epidermis, but the infection is really in the lower layers of the skin, maybe even down into the connective tissue. Before we get into cellulitis, I wanted to go over infections of the skin which are not cellulitis, just because being able to differentiate between them is going to help you identify what is what. So the first one on the list is impetigo, which is typically not seen in most adults, typically happens in young children. It is a strep or staph infection, which those are also the bacteria that are typically, probably in the vast majority of cases responsible for cellulitis. However, it's an infection of just the epidermis. So it doesn't go below the epidermis of the skin. And typically you'll see crusty lesions on the skin. It's very common, again, with young kids, especially if they're involved in contact sports or if they've been playing in like a sandbox or a jungle gym or something like that, where they might have come into contact or broken some skin. Another is herpes zoster, which is the shingles or the chickenpox. Anymore, most people get vaccinated for this, so it's not as common as it used to be. But it's characterized by grouped vesicles that are really itchy, really painful to the touch, and they're just really uncomfortable. Herpes simplex 1 and 2 refers to what colloquially people refer to as oral and genital herpes respectively. So herpes simplex 1 is usually what people refer to as oral herpes. Herpes simplex 2 is what people usually refer to as genital herpes. One thing that's important to note is that even though, again, a lot of lay people will refer to them as oral or genital herpes, herpes simplex 1 or 2 can be on either the oral or the genital regions, and they can even be in other places, even on the eye. So it's possible to get herpes in other places. These are grouped vesicles in both cases, and one of the characteristics of the herpes viruses is their recurrent outbreaks. So people will have outbreaks. Usually the first outbreak is the worst, and then over time the outbreaks aren't quite as bad. And then after a while it'll basically go into remission, so there's no more vesicles that are present. One thing that's important though is that when someone is in remission, when the vesicles are not present, the individual is still contagious and they are still shedding the virus. So it's important for people to use protection and protect themselves and others even when there are not herpes vesicles present. And then the last on this list is candidiasis, which is caused by Candida albicans. It's a diffuse rash with lesions around the affected area. This is usually seen in immunocompromised patients, so it's not very common unless someone, for whatever reason, is immunocompromised. It's common to be seen in patients that are on chemotherapy or sometimes who have HIV/AIDS. Now that we've talked about what cellulitis isn't, what is cellulitis? It's an acute bacterial infection of the dermis and the connective tissue under the epidermis. It usually is a result of a break in the skin of some kind. And the most common symptom is inflammation. It's red, itchy, painful, swelling. There may or may not be vesicles present, but generally it's just, a red inflamed region of the skin. The pathophysiology is pretty straightforward. There's a break in the skin of some kind, and that allows a portal of entry for bacteria and other microbes to enter in to the underlying layers of the skin and cause an infection. So the most common causes are Staphylococcus and Streptococcus bacteria, and the reason should be fairly obvious to everyone. The reason is because Streptococcus and Staphylococcus bacteria live naturally on our skin at all times. So typically if there's a portal of entry, they're the first ones to go in because they're right there on your skin. So typically when we're talking about cellulitis, we're talking about a staph or a strep infection. It can be other things, but those are overwhelmingly the most common. The signs and symptoms are consistent with any other kind of infection, except there's also a wound of some kind because, again, it is affecting the skin. So fever, chills, fatigue, weakness. There may be some tenderness of the lymph nodes. The site itself could have swelling. It might be warm to the touch. There might be pain. There might be itching. Generally, the wound is irregular in shape, but it does have defined borders. And probably a lot of y'all have seen cellulitis, so again, I'm kind of explaining something that you're all familiar with. But again, it's most of the signs of an infection combined with then what it would look like to have a rash or a wound on your skin. Other signs and symptoms are elevated white blood cell count, though another thing to keep in mind is that white blood cell counts may be higher or they may be lower. Either one is an indication of infection. If the white blood cell count is very high, that a lot of times means that the body's fighting off the infection and it's doing its job of mobilizing all of the white blood cells to fight the infection. If the white blood cell count is very low, that can mean that the body is not able to fight the infection and that it's doing a really bad job of it. And so especially in people that are immunocompromised or older adults, it's common for any kind of infection to actually have a low white blood cell count. So that still is indicative that there could be an infection present. This slide and the next are just pictures and examples of cellulitis and what it can look like. What it looks like varies a lot from the place it is and how deep the infection is, like where in the skin it is. So it can look a lot of different ways, but this is pretty consistent. Usually it looks like a rash almost. It just looks like a really bad rash. It's swollen, it's red, it's probably warm to the touch. It's pretty consistent with what you'll see in patients with cellulitis. So I want you to think for a moment about what you already know about infections and immunity, and then think about what populations would be most at risk for developing cellulitis. Take a few moments to think about that, and then I'll list a few, obviously not an exhaustive list, but a couple. So hopefully you paused and did that. So generally some populations. Any population of people that are obviously immunocompromised. So again, chemotherapy patients, patients with HIV, patients who are on any immunosuppressants for transplants. Additionally, individuals that are in close proximity to a lot of other people. So, nursing home patients, that's going to be a big one, right? Because a lot of times they have a lot of comorbidities. They're older, they have weaker immune systems, but then they're also in close proximity to a lot of other people. It's also very common that they get breaks in their skin because of pressure ulcers and other things. Hopefully they don't get those, but people do get them. Anyone who's another example of people that are in close proximity, people that are in the army, people that are in the prison population, anyone who has a high chance of having breaks in their skin. So people who are engaged in contact sports like football, boxing, wrestling, anything like that, there's going to be a high risk for skin breakdown or skin tears. Homeless individuals who are unable to find adequate places to sleep or house themselves. IV drug users obviously are creating a lot of tears in their skin. So again, that's not an exhaustive list, but it's, those are the kind of people that are most at risk for developing cellulitis. Take a moment to read over this question and then answer it yourself, and then I'll kind of go over the answer and why it's that answer. So hopefully you did that. Hopefully you either paused this or restarted it and thought about it a little bit. So the answer is C, the patient's temperature. And part of why that's the priority is because this lecture kind of serves as a lead-in, if you're listening to them in order anyway, to the next lecture that we're going to talk about, which is sepsis. And so very high or very low temperatures in the presence of an infection are a pretty strong indicator for someone developing sepsis, which is a life-threatening condition. So the others are all priorities, and they're all important. But for this question, the patient's temperature is probably going to be the number one thing that we want to be assessing for. If you said the blood culture, depending on what you're thinking about when we use the word priority, you might be thinking about like, well, obviously we need to get their blood culture before we start initiating antibiotics and start treating them. But even still, one of the first things that we're going to do if somebody comes in with an infection, we're going to want to take their temperature. So that's the answer. And obviously, pain is also a priority. People with cellulitis often have pain. It's usually not so severe that it becomes a major priority. Again, somebody comes in with an infection, probably the first thing we're going to want to do as a nurse is assess their temperature, or one of the first things. And then pulse and sensation on the affected extremity. You might check that, but generally, if somebody's coming in with cellulitis, there's not really any harm of the patient having neuralgia or like reduced perfusion to that extremity. It's usually not as big of a worry as something like sepsis. Treatment for cellulitis is pretty much the same as any other bacterial infection, and that is giving antibiotics. Typically, the antibiotics are given orally or sometimes topically. If it's a really severe infection where there's a really high risk for sepsis, or if the person has developed sepsis, then we'll give IV antibiotics. And probably a lot of y'all, maybe not all of you, but I would imagine a fair number of y'all have already taken care of patients that have maybe a wound that's become infected or some kind of cellulitis, and they're getting IV antibiotics. Typically, if it's a staph infection and we're worried about MRSA, or if we've confirmed that they do have MRSA, then usually it's vancomycin. That's a pretty common antibiotic that's used to treat this. If it's a drug-resistant strain, and that's what you see a lot in the hospital. Other than antibiotics, just rest and elevation of the extremity, warm compresses to help reduce swelling, and then depending on what kind of wound, if there is an open wound that the patient has, there might be a wet to dry dressing that's ordered. So there might be dressing changes. Not always though. Not all instances of cellulitis require a dressing change, but if they do, usually it's a wet to dry to help keep the underlying tissue viable. A few things to remember about patients receiving antibiotic treatment. First of all, before the patient's put on any antibiotics, they need to get a culture that is taken before the initiation of any antibiotics. So once the culture is taken, we can start them on broad spectrum antibiotics. We don't have to wait for the culture to come back and actually tell us what the bacteria is. And that's going to take, again, y'all have probably made petri dishes and things in microbiome. That's going to take a few days. So we don't want to wait a few days to start them on antibiotics. But we can start them on broad spectrums. And then if those aren't working, or once we get the results back and we need to be a little more effective, then we can move them onto more targeted antibiotics. But we do need to at least draw the culture, or cultures if we're doing like pan cultures, which would mean getting it from the urine, from the blood, and from the wound, and from the sputum. But any cultures we need to do before we initiate antibiotics. The other thing to remember is that if someone is sent home with antibiotics, because not everybody that gets cellulitis is in the hospital, right? There's a ton of people, you have a young, like 18-year-old, they get cut or something playing a sport, and then they get cellulitis. They're probably not going to be admitted to the hospital unless they have a really bad case. So a lot of times they might get, an oral dose or a topical dose. So don't forget, we need to teach them to take the entire regimen, the entire course of the antibiotics. Don't stop taking them once you feel better. You need to take the whole thing, because if you don't, the infection can come back, or it helps contribute to drug-resistant strains. And then if they are getting IV antibiotics, it's really important to monitor any peak or trough levels. And those are really common with vancomycin. So typically we draw a trough level before every third dose of vancomycin. So you need to be paying attention to when the third dose is and what the trough level is, because oftentimes we'll adjust the dosing of each of the course of the vancomycin based on what the peak and trough levels are. So make sure you're getting those. Don't give the antibiotic, just because it's ordered and you haven't drawn a trough level. So really pay close attention to that. To wrap up, I want you to think about some nursing diagnoses or patient problems for someone that has cellulitis. What are some of the goals that you would set for those nursing diagnoses, and then what are some of the interventions that you'd use to meet those goals. So basically develop a mini care plan that you would imagine that could be pretty universalized for patients with cellulitis. Thanks.